You're listening to This Might Sting a Little.
The podcast where three doctors tackle medicine, myths, and madness.
With a healthy dose of sarcasm.
I'm Dr. Duncan Turner.
I'm Dr. Dennis Hughes.
And I'm Dr. Orel Swenson.
This is No Wine Fest. It's about to get clinical with a twist.
So thanks everybody for listening, for those of you tuning in today. So I'm Dr. Orel Swenson, former emergency medicine doctor. Previously worked a number of locations, including freestanding emergency departments, level 1 trauma centers, Johns Hopkins, and worked in inner city Baltimore as well, before finally transitioning into a much more leisurely career in the regenerative medicine space. I'm joined today by Dr. Dennis Hughes and Dr. Duncan Turner as well, and we're going to talk a little bit about what the emergency department's like from both a patient and physician perspective, and delve into why it can seem like such a painful process when you have to go in.
Wow, you could be an auctioneer.
Why was that fast?
It was good.
Yeah, it's clear.
Habada.
So, picking up a little bit from where we left off last time, we had started to talk briefly about the emergency department. And as a former ER doctor and also a patient at times, I certainly have seen both sides of the coin. I've been fortunate, let's say, to work across a vast spectrum of emergency departments. I've been in freestanding small hospitals, level 1 trauma centers, and more or less everything in between. And universally, unfortunately, the patient experience is typically quite bad, no matter why they're coming in there. I think it's useful to unpack a little bit what exactly is happening kind of behind the scenes for an emergency department. Why do you end up there waiting 6 hours, and while you're in pain, you have a fever, and you're clearly sick as well, but what's happening that's stopping you from moving forward? And of course, from your perspectives, I'm sure as you send patients to the ER, it's never a pleasant experience. They're calling you to try to avoid having to go in if possible. Right. And why do I have to go to the ER? What can you do for me that, what are they going to do that you can't do for me? But I'd love to know, how do you guys address this? I think would be a useful starting off point when you're talking to patients about why they might have to go in. They're giving you potentially pushback about having to do this. And it's not like you're going to the ER and having an appointment. You've cost the day or the night for sure. No one goes to the ER and is out in 10 minutes. You're there for 4 hours. Right. Before you even get in the car to drive, you're there for 4 hours.
Well, they have Netflix on their mobile phone now.
Helps.
They can watch a movie.
It helps, but sometimes there's no signal and the Wi-Fi is terrible. So
I think that it can help the patient's journey, maybe even before they get to the ER, if they know that you as the physician have called the ER and let them know that you're bringing a patient in or you're sending a patient in, and this is what you think is going on, and maybe a reason why you feel they need to be in the ER, because there's access to everything that they need. And to the patient, you basically make the case that this is where you'll get what you need. And there may be a long wait because you never know what else is in front of you on the line. And so I think softening that blow can come, we can make that better.
Yeah, I mean, I'd like to hear from you too, I'm sure, but one of the things that I'm sure you get feedback on is even when you call ahead, and now in my current practice, interestingly enough, I also send patients to the ER sometimes and call ahead, and it's not uncommon, I'm sure you're going to say the same thing, to say, well, they didn't get the note. No one heard from you. What were you talking about? Did you even call in? Did no one could find the information you passed along? I'm happy to expand upon why that happens for the audience out there, but Dennis, I flip it to you as far as your own experience there.
I think older people sometimes are reluctant to go to the ER because they're afraid they're going to be admitted and, they're going to be stuck in the hospital for a long time. They want to be in their house. But thankfully, I haven't had a lot of pushback from patients. I think that as a primary care doctor, knowing patients for many years, there's a trust that develops. And, I explain, like you do, to the patient that, look, this is going to be a streamlined process. If I'm trying to look at your problem like abdominal pain by CAT scan, it's going to take a week before I get it approved. Whereas the ER is going to get it done and bring the threat level down. Either there's something really pressing, you have to be admitted or not, and I'll finish the workup more slowly as an outpatient. But I think, fortunately for me, there hasn't been a lot of pushback. Because I explained that it's going to be a faster process in the ER with something urgent, and also that level of trust where the patient might say, look, I trust him. And if he says I need to go to the ER, I need to go to the ER,
Yeah.
which I appreciate.
Fair enough. Yeah, I actually had a patient to send in this past Friday, the same idea. Came in to the office, wanted me to look at her chronic wound, looked at it, it had gotten worse. She says overnight, the whole lower leg is swollen. There's the bedside ultrasound is obviously tracking up through the musculature from this chronic wound she has. And this conversation was, well, you can spend the evening in the ER and get all your testing done and your necessary imaging done and your advanced antibiotics given to you right then and there. Or I can try to coordinate all this as an outpatient, and your labs will be done. It's a Friday, so maybe we can get you in today. Labs will come back on Monday, plus or minus imaging over the weekend. So we're going to lose 4 days of treatment time. Into the ER she went. And yeah, I mean, that was the evening. She left the office at, I don't know what time was it, 10 o'clock. And I next heard from her 8 or 9 o'clock at night before she got home. But it's much more efficient, even if it feels inefficient.
Yeah, but let's look at a few details about what you said. I knew nothing about this patient of yours. We haven't talked about that before. But you were there till 10 o'clock in the office.
I saw her at whatever it was, 10, 11 o'clock in the morning and sent her to the ER. Yeah,
Okay.
and she was in the ER until 8 or 9
Yeah,
o'clock at night.
okay, I could understand that.
Yep.
But and again, it's a Friday too.
Mhm.
It's you're not going to get anything done. There is nowhere that I know of where you can get a stat blood test other than the ER. I mean, maybe something you can get at urgent care, but it still takes a while. And if you send them right to the lab, well, the lab is only related to the lab where they do the measurement by a pickup twice a day or about that. So it's just, you can't do so much to help in some of these things where you just I need to know what a white count is,
Right,
It
exactly. Need lactic
just
acid
give me
right
that.
away. Like, what am I supposed to do?
Yeah.
Yep.
So I don't feel that it's a problem to persuade patients to go there. I mean, they don't. I think maybe it's trust, but even so, it's maybe patients I've never seen before that they still need to do it. But having one recently, a patient with an appy, and she had seen another physician. She had a normal white count, and she had some right lower quadrant pain, but she just, when I saw her, she looked sick.
Yeah.
Yeah. And she didn't have a fever. She just looked sick.
You had that feeling.
You can tell. Mm-hmm.
And so I sent her to Goleta Valley because I thought that would be likely to be less crowded than Cottage. And it was something that, wasn't life-threatening at that point, but needed to be dealt with because we were, Thursday night or something like that. And so I called, talked to a nurse, and beyond the person who just answered the phone in the ER, I talked to a provider and said what I was thinking. And she went there. She went straight from my office to there. And I didn't hear anything for 3 days until she called me back and said, I had appendicitis. I had surgery that night. They were great, and I wanted to let you know. But the docs didn't let me know. The patient did.
No,
but
we will.
But it was, and that's okay.
It's just not something that's in our.
If that patient has gone to the ER, I feel comfortable with that. I've done what I need to do.
Yeah,
they're in good hands. And there may be hours of wait. But either now or later in our discussion here, talk about the reason why people have to wait very frequently, or some people don't have to.
Yeah, well,
you don't want to be.
You never want to be that person that's not waiting.
That's right.
Yeah, but then I think you had something you were going to throw in there first.
Oh, no, I'm sure you guys have all been through this. Sometimes you're sitting in front of a patient and you're thinking, should I really send this patient to the ER?
Mm-hmm.
Because maybe it's on the fence. Inevitably, after they're done with the ER, I'm always happy I sent them. Now I can relax. Either something had to be done or everything's been ruled out, and I can deal with the rest as an outpatient. But because we all walk down the street and sit in our car driving thinking about these patients' cases. Did I do the right thing?
Yeah.
But the ER gives me a measure of security that things have been done and looked at in a right amount of time.
Yeah.
Right.
Yeah, I think there's a few useful comments also to call out for, again, patients of ours that are listening, which is to say, unlike everything in the outpatient world, you don't get denied in the emergency department. And I mean that in multiple ways. So the ER is required to see anybody that walks in, period. That is literally federal law. You have to see them. You have to stabilize them, and that's a whole conversation to unpack. But at the very least, you've got to, get them to a place where they're safe to walk home. And that might mean that they don't go home, that they're staying in the hospital, whatever it is. So not only can we not deny anybody, which is a good thing, we also don't have to pre-authorize anything. If I want an MRI, if I want a CT scan, I can get it right then and there. There is no question about it whatsoever. Now, that doesn't mean that there's not some enormous bills coming out of the emergency department for patients sometimes.
That's another point.
That's a whole other conversation that, I can't factor in on the ER side to my decision-making process. Once they're there, I'm doing what I have to do. So we get it. Patients can sometimes see obscene bills afterwards because high deductible insurance plans, et cetera. But nonetheless, the testing is done. They're safe, if nothing else. And money is money, but at least you have your health, so to speak.
All right.
Yeah. So to your point, as far as who has to wait in the emergency department, it always feels like everyone has to wait in the emergency department. So for a little background knowledge, and you guys probably know this, so the ER in the US and I believe Canada as well works off of what's called the Emergency Severity Index, or ESI level. That's a 1 through 5 score. 1 is you've been shot, CPR in progress, very, very bad things are happening. And 5 is, and I say this with no rudeness intended, a homeless person walking in looking for some place to literally sleep for a few hours and just being hungry. And we get those, or a medication refill. Clearly not an emergency, didn't need to be there, but they have to be seen. So you never want to be number 1 by any means, obviously, because that's kind of where that comes from. And then, from there, it's not a deli counter. You don't come in and you get your number. There might have been no, going back to the ESI term, there might have been no ESI 1 or 2 when you walked in, but an ambulance shows up, a 911 call goes out, and now 3 or 4 of them are in front of you. And all of a sudden, what would have been 5 minutes is now 30 minutes, 40 minutes, 3 hours, 5 hours. The patient I sent on Friday, who I also called in for, and I never heard back about. Because when I called in, so the ER, the other thing, part of the reason that I think people can get frustrated on the call-ins, that is when we call in for them, it's shift work based. You don't talk to the ER doctor, you talk to an ER doctor who might be at the end of his or her shift, getting ready to go home, just getting started, in the middle of a critical patient. This has happened where I've taken a phone call on a patient who's coming in. Great, but in the middle of CPR, when that patient rolls in, another doctor picks them up. That message never gets relayed, and there's nothing I can do about it.
Right.
So there's a lot that goes on behind the scenes that, explain really why this is such a slow and difficult situation. That's to say nothing of, I'll turn this to you from the hospital side, the bed turnover and the need to get patients out of the ER to see the next one. So yeah, there's always that backlog as well.
I used to work in the Bay Area, and I would send my patients to Sequoia Hospital in Redwood City. It's a smaller hospital. And I really enjoyed that smaller caliber of a hospital because I knew the ER doctors by name over many years, and I could always pick up the phone and have a conversation. Mm-hmm. This is what's coming your way. I'll never forget this patient I had. He was in my office with an appendicular abscess. He had some discomfort in his right lower quadrant, and he came to me with a golf ball down there. And I tried to call this ER. It was a large university ER with like 9 attendings at the same time. And I tried to call report. They wouldn't even talk to me. They said, no, just send him over. We don't talk to doctors. I was like, that's weird to me.
I doubt it was policy. It might have caught somebody in a mood, but at the same time, it often doesn't get related. I mean, if you're talking a large academic center, you might have 5 or 6 residents, 4 or 5 attendings, 20 odd beds or more. I mean, what I trained had, I think 60 beds at one point in the ER alone. Yeah, there's just no way to communicate effectively until they're there, and it's whoever grabs the chart, quite frankly. So, yeah.
I always feel better.
Kind of one of those, don't call us, we'll call you. I don't say that to be defensive. It's just the nature of what are you going to do? You're going to pass along a message to nobody.
Yeah, I just always feel more comfortable when I close the loop and have a direct conversation. Yeah, because maybe the patient is not going to tell the story like I would tell it. So
that's exactly that's exactly the issue. Yeah, and it's one of those things. I mean, when we talk about patient advocacy and part of what I try to offer here in my practice as well is I'll call and talk to the ER doctor for you while you're there, because exactly you just said, patient tells a story, we hear different things than they're saying based on, again, our filter and our medical lens of it, so to speak. So it's useful to pass that along whenever possible.
Yeah, it's strange how the stories change from the way we say it to the ER as opposed to the patient. But the other thing about the ER is that you mentioned the people that are more like the 5 out of 5, they're 5, 4 or 5.
Yes.
Okay, and they really don't need to be there, but so much of the population, in my experience, uses the ER as their GP.
Very much so.
And they show up because they know they're going to get treated, seen, and they might not have anything else to do for that day.
There is very much so truth in that. Mm-hmm.
I noticed this working up in the Bay Area over the last 10 years, and I mean, it's really hard to look at the amount of time that somebody has been in the ER before, and it's shift changes, as you say, and just some small point gets forgotten or missed, and they're just, and these patients come in with, a fever and abdominal pain and bleeding, and what do you mean you're calling me now? And the patient's been there for 15 hours. It's this when this could have been taken care of in 15 minutes. That length of time ago, and as you say, with the pattern in the ER also is to make sure you don't miss anything.
Exactly.
And which means not over treating, but over evaluating patients. Everybody gets a CT, almost.
I mean, within reason, but yes, again, because it's a self-selected patient population, as you guys just kind of described yourselves, right? If you've sent them to the ER, you already told me that you don't have the resources or the time to wait.
It's an emergency.
Therefore, they are clearly at a higher risk. Yep.
Right.
So there's that aspect to it.
Yeah.
And, patients probably are less interested in this, but the malpractice considerations are very different for the ER than the outpatient world. What we're allowed to, quote unquote, miss versus what you're allowed to miss. Mm-hmm. If you tell me you have a patient who sees you on a Saturday afternoon for potential appendicitis and they get sicker because they didn't go to the ER or whatnot, well, you do what you're supposed to do. If they come to the ER and it might be appendicitis, I have every tool at my disposal. How can I justify not using them?
Right.
It's a good point.
Yeah.
I said this to you before. I like the over-evaluation.
Yeah.
Job is done.
The job is done. Exactly. Yeah, but it's also the societal safety net, which is where it's we're not just seeing a bunch of people with CPR in progress or appendicitis. We're seeing a lot of people who you don't have to bring your insurance card to the ER. You get seen, period. And
I wonder if it'd be a good idea for these patients that we send, that we have some note to give with them.
Oh yeah.
Always
helpful.
I'm gonna phone the ER, but that, as we've discussed, can not always work. But if we did just give them something, a hard copy of something.
Yep.
That's actually a good point for people that are in your office to hand it to them if you can.
Yeah, just give this to the doctor.
Pretty much.
Okay.
I mean, very helpful. I've gotten that a few times on the ER side. Very helpful.
I've always either faxed my notes or, if I'm lucky, the hospital system is on the same EMR as my office. They can just look in the EMR and see it. But I can see if the patient's in front of you before they leave, to give them the note would be best if you can.
Yeah.
Obviously, it's going to be different if you're talking to them and they're at home.
Yeah,
but, you talk about the wait time, and it takes a long time. But I have to say, I think there's just a cultural expectation we have in America where everything's going to be right away for us. Maybe in other countries, people are just happy to have the care. Okay, I'm going to have to wait 4 hours. Someone's going to look into my belly pain. We expect, like that.
That's a very good point.
There has to be a little patience going on. The word patient can be ironic sometimes.
I was going to say, from the patients, yeah. But I think it kind of recaps at a high level a lot of that. And there's a lot to unpack, right, in terms of system abuse and it's serving as society's safety net, and whether or not the ER is used correctly and by who and whatnot. And there are so many points and counterpoints to get into there. It's not even a realistic conversation, right? You tell me, well, you shouldn't be here for your medication refill. They say, I can't get into my PCP for 6 months. What do you want me to do? Not have my blood pressure medication? Okay, well, what do you do?
Not to mention all
right.
those people who don't have any insurance, and they just wait until something blows up and they end up at your doorstep.
Exactly. So it's a tough environment, to be sure, from the physician side. Yeah.
You chose it.
The other thing that's
I
different from when I first came to town, which is a long time ago,
Few weeks.
is that I would meet the patient in the ER. I would, if I was sending them to the ER, and actually whether I'd seen them already or I had just been on the phone.
I have to say, I've heard stories of this.
Unbelievable stories.
Never saw it in my lifetime, but I've heard stories of this.
But the thing is that I've done that until recently. I mean, I within the last probably 2 to 3 years, I have met a patient in the ER.
Fantastic.
But I haven't got a clue in the ER where to go, who to
Right.
talk to, who's who.
Yep.
And looking pretty much like an idiot, or being
It's just-
questioned
yeah,
by
like-
somebody who thinks I'm sort of stalking and trying to check out who's
Who are you? What are you doing
what
here?
news is there that's of interest today. Do I recognize any of these names on the board?
Yeah.
So it's that's another thing that's changed significantly. But
Very much
I mean,
so.
your comment is just as amusing because that isn't something that's done much anymore.
Yeah, I was an attending physician starting in 1999. I used to see my own patients in the hospital,
And
or I'd
admit to
meet them in
yourself,
the ER
right?
and
Yeah.
admit them. And when people started using hospitalists instead, I thought it was strange at first, but now I accept it. It's actually better for the
It
patient.
might be worth explaining what that is and what that change is.
Okay, a hospitalist is a physician that does not treat patients in the outpatient setting. They only treat hospitalized patients, and they're there all day and sometimes all night, depending on the hospital. And I really am happy that there is a specialty called hospitalist, because I think for a patient to have something bad happen during their hospitalization, I'm in the office seeing patients. What am I going to do? I can't bump everybody off their schedule
Right.
and then run across town, see my patient, and then come back. It's just chaos.
Yep.
I remember I used to go to the hospital in the morning, and I'd look for my patient, and I would see the IV line going under the bathroom door, and I'd be like, oh, or, and I got to get back to the office in half an hour, or they'd be at a CAT scan or something, so I'd have to run back to the hospital at lunchtime. I got a bunch of speeding tickets.
We used to do rounds twice a day on our inpatients.
Wow.
Was
Was your office right next to the
This is more than
hospital?
40 years ago. Yeah, it was, fortunately.
Okay. Yeah.
But a lot of people did that. Yeah.
Yeah.
Times have
Yeah.
changed
It has, yeah.
for the better
Mm.
I suppose.
in some ways.
I don't know. I wasn't there for that part.
It's,
There is loss of continuity by using hospitalists and whatnot from that perspective. They don't know you as well. I don't know a patient in the ER as well. But
right.
at the same time, to your point, I mean, there's in some ways no way around it, because what are you going to do? You can't actually hold their hand the same way as soon as they're in the hospital. You still have your office practice to maintain. So
It might have been a problem in my specialty of OBGYN because none of the ER or none of the hospitals up until a few years ago had in-house gynecologists or OBs to see patients. And so you basically had to.
yeah,
And although there's a surgical residency program, they would not see your GYN patient, even if you thought they were a surgical candidate, unless you could refer to them for them to do a consult.
right.
But they wouldn't continue to look after your patient unless they determined it was definitely a surgical procedure. So
Yeah,
now that's changed because there are laborists and hospitalists,
yeah.
it's clearly better this way. But
Laborist. Great word.
a laborist.
Haven't heard it.
I haven't heard either. Yeah.
Looking after patients in labor.
Got it. You must have lost a lot of sleep back in the day, getting called all hours of the night?
There were reasonably comfortable beds there. We had to sleep. I've never actually lost a complete night of sleep in my career. I've been in the hospital at times. May only have been an hour or so of sleep that I've got, but I've never missed
true
the
all-nighter,
entire one. And that part of that is because if I have the opportunity, I can go to sleep in 30 seconds. That's right.
My first residency rotation was the trauma ICU, and it was 36 hours, and I did not sleep at all.
Yeah.
I remember.
I had
I
those
guess
nights.
I remember it. I don't really remember the shift per se, but I was there for it. I know that.
I remember once I was so tired, 36 hours up like you.
Yeah.
The nurse really, she had her hands on my arm and was dragging me out of the bed. She couldn't wake me up. She had to throw me out into the ICU nursing station.
Good points on my son. Yeah, woken you up. Well, what's a good recap for us? What do you think some take-home points are here? I guess I'll let you guys each throw one out first, and I'll give a little wrap as well.
Well, my thought is try to get some communication to the hospital, to the ER, if you possibly can, whether it's talking to somebody or even giving a hard copy, as I suggested.
Yep.
I mean, that I think could be really beneficial. But they still may be there for hours because
For sure.
that may be the circumstance at the time.
But putting it in physician words is often more helpful for the ER side to take action on.
Yeah.
What did you hear that made you send them here?
Right.
That's not necessarily coming across right now. Because they get to the ER and it's been 3 or 4 hours. The leg's not as painful as it was 3 or 4 hours ago. So they show up, oh, I didn't have a fever. It feels better now. So it's like, well, what are you doing here?
Yeah.
Well, actually, this is what happened. Override swelling and fever,
Right.
The story changes a lot from hour to hour as people feel better. And then memory is very fragile. Let's go with that in terms of all the details.
I think the patients are pretty lucky here, given that we have a small couple of towns here with a couple of hospitals.
Yep.
Yes, they have to wait a few hours in the ED, but they don't have very far to drive. Imagine you're in the boonies in Nebraska somewhere. You got to get in the car, drive a long way, and wait.
I've been in that, yeah.
But I agree. I really have nothing to add to that. I think the communication is really important, and just a follow-up call to the patient after they're out of there.
Yeah, I mean, we want to hear from you too, as far as the patients go. We want to know what happened once you get out of there.
Yeah.
We're curious.
That's right. No news is not
realize the
necessarily good
hospital
news.
often hasn't called because they can't. That wasn't the time for it. So
Yeah. Right.
yeah. Well, I think more or less a wrap there. Yeah, absolutely. I think it's worthwhile to just be happy that you're not in the front of the line if you're in the emergency department.
Really.
Is the best I can say, and understand that your wait time might be going up minute by minute, but it's because more than likely something bad happened behind the scenes. So there's just a very unique flow to an emergency department that you don't see pretty much in any other setting. But it also doubles as a substantial safety net for most of society here, including anybody who's uninsured, and serves a purpose much broader than I think we sometimes give it credit for.
Absolutely.
I agree. So you used to do good work.
Used to do good work. Yeah, exactly. Exactly. Now I try to keep them out, but every now and then we have unavoidable. All right. Well,
Thanks.
Thank you.
Yeah.
It's fun.
And until next week.